Okay, we're gone.
I can go. Okay. Hi, everybody. Can you hear me? Can you hear me in the back of the room? Okay. My name is Sharon Meyers. For those of you that don't know me, I'm a nurse and also other things. But so today we're going to talk about atrial fibrillation. How many of you actually have atrial fibrillation? Quite a few. How many of you know that you have atrial fibrillation in your family, like a mother, father, brother, sister, grandparent? Yeah. Okay. How many of you are worried about getting atrial fibrillation? Not so much. Okay. So let's move forward here. So what is atrial fibrillation? So it's the definition is it's irregular, kind of chaotic. So there can be things that are irregular, but they're kind of irregular in a regular kind of manner. But atrial fib is irregular and it's kind of chaotic. So it's called irregular rhythm. That comes from the atrium. What's the atrium? Atrium is the top part of the heart. So that's right up here. These are the atrium, these are the ventricles. So normally the SA node starts a little trigger that tells that atrium to beat together, and then it sends it to the AV node right there and tells the ventricles to beat together. And the beating together is the thing that really works well for us. If the atria don't beat together, or the ventricles don't beat together, we don't get as good of a cardiac output or as good of amount of blood going to the rest of the body. So that's kind of key there, is that togetherness. So when we have atrial fibrillation, instead of having this kind of togetherness, the top part of the heart's beating kind of like this all over the place. And then the bottom part of the heart eventually gets the message, and it beats, the ventricles beat together, but they beat more times than usual because they're getting a lot of messages coming through. So this is what it looks like on an EKG. And you can see the top one, that's called the normal, it's called normal sinus rhythm, or the normal heartbeat. And what you have here is that little blip, the tiny little blip. That's the atria beating together. They're all in synchrony. You don't see a bunch of little mountains there. You just see one. Sends a message to the ventricles, which are bigger. They beat together, and that's what you see. And then the heart recovers. So atria, ventricles, recovery. Very organized, very orderly, nice cardiac output with that. On the other hand, look at atrial fibrillation. This is the atria getting these chaotic messages. They're kind of part of the atria is beating here, the SA node's beating, and then these other little parts from the atria come in and they beat. And so you kind of get this, you don't get a good output from the ventricles. They're not beating together. Eventually, the ventricles get a message and they beat. Sometimes they get a message from some random place in the atria and they beat. So the whole thing is kind of chaotic. And because of that, you don't have a good cardiac output. And if you don't have a good cardiac output, you don't feel that great. You can feel kind of lousy. Your blood pressure is not as good. So you can think of atrial fibrillation like there's several conductors directing an orchestra instead of just one. Imagine if you had an orchestra and you had the main conductor that was up there and really knew what they were doing, and you were used to that conductor, and all of a sudden you look up and there's four other conductors up there. They're all flailing around, and you're trying to watch the main conductor, but these other guys are in front of you and they're bigger, they're making a bigger scene. So the ventricles and the AV node, they don't know who to follow. So they just start letting whatever come through. So there's a lot of chaos going on there. So the music loses its rhythm, and the same thing happens in your heart. The ventricles lose their rhythm. And these little rogue pods that are in the atria, these little guys up here, this is what's supposed to be the director, and it's still directing. You can see it's still sending out messages, but you can see these other little pods or other little cells are trying to take over, and they're sending messages too. So they take over, and eventually, at first, when they start to do it, these little guys that are trying to take over, the main director, who's stronger, kind of gets back and gets in charge. And so these little cells that try to take over end up kind of having to step to the back. But every time they try to take over, they develop this little pathway in the heart. And then the more that they do it, the stronger that pathway gets. So that's why atrial fibrillation can start out as just a little, 2-minute bout of atrial fibrillation. And then it goes away because the main director takes over. But eventually those little pathways, they get stronger and bigger, and they can become the main pathway that's in charge. So I'm going to show you a little YouTube video, I hope, with a similar explanation. Uh-oh, what's that, Linda? There we go. That's it.
When you're in atrial fibrillation, you are no longer under the control of your normal source of electricity. An abnormal source of electricity has taken over control. Literally, another wall of your heart has formed a separate source of electricity that is now controlling your heart. Pretend for a moment that another wall of your heart actually formed a cluster of abnormal electrical cells. Cells that aren't supposed to be there. That's why I'm calling them abnormal. And let's also pretend that these abnormal cells have the same or similar ability to create electricity and control your heart, just like your normal source cells. But they're not your normal source cells, but they're very similar and they have similar properties and can do the same thing. If you did form another set of cells that could create electricity and control your heart, now your heart effectively has two separate sources of electricity. And you don't want there to be two sources of electricity. They will not work together. They will fight with each other for control of your heart. Why? Because your brain doesn't control the abnormal cells. It only controls the normal cells. The abnormal cells have a mind of their own. They're like rogue cells that could do literally whatever they want.
But I don't see a in there. Oh, it is Gabe. He did use the word cell, by the way. Yeah. Okay, did that make sense to everybody? Okay, great. So that's what atrial fib. And how prevalent is atrial fibrillation? Your lifetime risk of developing atrial fibrillation is about 1 in 5 among individuals who don't have other risk factors that make them more prone to getting it. So 1 in 5 for people who don't have a family history of atrial fibrillation. They don't have obesity, they're not smokers, they don't have diabetes, they don't have high blood pressure, all those things. If you have none of those things, then your chance is 1 in 5. But if you have any of those risk factors, then your chance is 1 in 3, which is pretty high, of developing atrial fibrillation. 10.5 million in the US have atrial fibrillation, which is 5% of the population. And they didn't expect this when they first studied atrial fibrillation. They expected by this year, or I think it was by 2023, that 8 million people would have AFib. So it's going up faster than we expected. And it's expected by 2030 that 12.5 million in the US will have atrial fibrillation.
That's because there's more older people? Or
Yeah, why do you think that is? Why do you think that number's going up?
Orange.
Yes, there's more older people because we're living longer, because medicine is allowing us to live longer. This advances. Also, the baby boomers, there's a lot of us. So there's just more people that are older. Why else do you think it's going up faster than expected?
David, just shout it out.
Yeah.
Because they see it more often.
Yes, they're able to detect it. So yeah. Yes, we're better at detecting atrial fibrillation. Any other reasons?
Nanoplastics.
Yeah. Nanoplastics, yeah. Well, we don't know about probably plastics. But yeah, I mean, 20 years ago when they made these predictions, we didn't have the obesity and the overweight rates that we have. We didn't have so much processed food. Hypertension was lower. All those things were lower. So now we have more risk factors. People have more risk factors. And if you have more risk factors, then you're going to have more people that actually develop atrial fibrillation. Yeah, I don't know. It's interesting. Yeah,
Do they?
yeah.
The doctor that did my,
No,
or maybe worse, maybe that's.
you can see at different ages, it's almost equal. But when it gets to the oldest age, which is greater than 85, then there's more males. But 80 to 84, interesting that there's equal amount. And once again, you wonder if detection is involved in some of these numbers, because we don't always know if we're having atrial fibrillation. We'll talk about that in a little bit. So these are some of the risk factors for developing atrial fibrillation. Things, when I say risk factors, I mean things that put you at higher risk, make it more likely that you will get atrial fibrillation. If you have a genetic predisposition, as you get older, if you have problems with your heart valves, it just changes the size of your atria and your ventricles. And if you get an enlargement in your atria from something, that can trigger these little cells to start firing, and you can end up with atrial fibrillation. Having blockages in your coronary arteries, having had a heart attack, any kind of congenital heart defect, previous heart surgery, once again, it kind of changes the structure of the heart and makes it so that these cells are triggered and more likely to take over. High blood pressure puts pressure on the heart, also changes the structure of the heart, and same thing, makes it more likely that you could develop atrial fibrillation. Sometimes that main pacemaker of the heart is not functioning correctly. And so if it's not functioning correctly, it makes it so other cells will take over.
Did you?
Yes.
I didn't hear, did you mention because we're more sedentary? We sit, we
Yeah.
ride in our cars. we
Yeah.
don't-
Yeah, that's not on this list. But we're going to talk about exercise. Yes. Inactivity is put you at greater risk for atrial fibrillation. And we'll talk about this, but intense endurance type of activity puts you at greater risk for atrial fibrillation. So people that are doing long running across the United States and that kind of thing are more likely to have atrial fibrillation. Well, we're not going to be doing that, running across the United States. Think problems with thyroid gland, having diabetes puts you at higher risk. Use of stimulants, and they consider alcohol as stimulant. So alcohol associated with greater risk. Smoking, certain medications, use of cannabis, sleep apnea, a big one. Sometimes people, don't have atrial fibrillation. They get it taken care of, but they don't realize they have sleep apnea, and that can be a trigger to cause the atrial fibrillation to come back. And then stress due to illnesses, and also psychosocial stress, and then viral infection. So how do we diagnose atrial fibrillation? So many people feel atrial fibrillation. They can feel it in their chest. They feel it in their throat. I didn't look this number up, but a lot of people don't know that they're even having atrial fibrillation, right? So that's why I wanted to talk about this today. How can you figure out if you know, how can you kind of monitor yourself and have a better understanding? But if you go see a doctor or a healthcare worker, this is how and you come in there and you say, well, I've been tired and I've kind of been feeling, this thing in my throat, kind of fast beating. How they diagnose atrial fibrillation is they'll immediately take your pulse and see if you're in it right now. And you can feel it in your pulse. You can feel an irregularity instead of feeling just like dump, dump, dump. It'll feel like dump, 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 dum, 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 that kind of thing. You can hear it with a stethoscope. If you're in atrial fibrillation, we go in and out of atrial fibrillation when we first get it, right? So you could be feeling lousy at home. You go see the doctor, of course, you feel fine and they don't hear or feel anything. That's the trouble with atrial fibrillation at the beginning. An EKG will show it if you're in atrial fibrillation. It's not going to show it if you're not. If it's pretty progressed, if you've been in atrial fibrillation for a long time, you may see some changes on the EKG where you see that P wave is larger because the atria have gotten larger. Well, they can, but it's not necessarily going to occur. So he asked if you could order a treadmill stress test to diagnose it. So, exercise doesn't always trigger atrial fibrillation unless you're doing excessive exercise for a long period of time, usually is what it is. So it may or may not show up with a stress test. So that's not one of the typical ones, but wearing a Holter or some sort of event monitor for 2 weeks is a good thing, because it's probably going to, if you're having intermittent episodes, it's probably going to appear during those 2 weeks and show up, which is nice. And an echocardiogram can see if there's changes in your heart, which indicate that you may have atrial fibrillation, and then they'll do further testing.
Can you tell if someone else is having it? Sometimes I think my son gets overly excited over me, worries about me. I think sometimes he must be having insurance red.
Yeah, with atrial fibrillation, you can't really tell by looking at somebody. We're going to talk about the symptoms. Oh, what it looks like. We'll get to that. Good question. Check the pulse is the main thing if you're able to do that. So they classify atrial fibrillation into kind of 3 different types. One's called paroxysmal, which just means that it comes and goes. And that's typically the way that atrial fibrillation starts, where you have a spontaneous run of atrial fibrillation. It typically stops within 48 hours. Usually at the beginning, it'll stop within an hour. It may stop within minutes, but definitely less than 7 days. It doesn't last longer than that. And it comes and goes, and then you'll be just a normal sinus rhythm. Then it can develop into more persistent, where it doesn't just stop. It lasts greater than 7 days. Or you may have had a cardioversion, which is something that can shock you out of it, and then it comes back. Once it comes back after a cardioversion, or you take medicines for it, they take it away and it comes back, then they classify it as more persistent atrial fibrillation. And then the final one is chronic, where your doctor's tried many things. They're not able to get you out of the atrial fibrillation, and you're just kind of trying to live with the atrial fibrillation. It's called chronic atrial fibrillation. The arrhythmia pattern is very well established. That little pathway that I was talking about, the when it first starts, it's very weak. It's pretty strong, and it's kind of taken over. Yes.
If you have had whatever, if you had it once, what is the probability of having?
Oh, yeah, he asked if you have paroxysmal atrial fibrillation, which is short little runs once, what's the probability of it happening again? I'll have to look that up. I don't know the probability. You can't just have it once and then not have it for years. I know for sure, like if you have some sort of really intense viral illness or something like heart surgery, where your heart's just kind of enlarged from fluid and stressed from the surgical techniques that they're using. And I'm not sure, if it always comes back.
And to bring the person back, or they ever use paddles?
Yes, cardioversion. We're going to talk about that. Yep. Good questions. Good question. I'll have to look that up. If you have it once, is it pretty sure that you're going to get it at some point again? So this is kind of the way I talked about this already, that atrial fibrillation progresses. There's a starting point. Certain individuals are born with a higher susceptibility to atrial fibrillation due to their genetic makeup. Atrial fib is very commonly passed down in families, and it sets you up for getting atrial fibrillation, especially if you have a genetic predisposition, and then you also have one or more of the other risk factors. So age, we can't stop that, right? So as we get older, if you have a genetic predisposition, you may suddenly just develop, even if you don't have hypertension, or you're not overweight, or you're not a smoker, or you're not taking drugs that are stimulants. So as we get older, the likelihood of developing atrial fib increases. As we get older, there's just some structural, even if we're doing everything right, there are some structural changes in our heart that occur that just make it more likely that these little rogue cells can kind of take over. And as we get older, there's an accumulation of other risk factors. We get a little bit of high blood pressure. We might develop type 2 diabetes. Those kinds of things happen. And then there can be structural and functional changes of the heart when we get atrial fibrillation. Imagine that atria, instead of just going like this, it's just beating all the time. So that atria is a muscle. What happens to your muscle if you use them? They get bigger. Same thing happens in the heart. That muscle gets bigger but it's not in a way that's very efficient. It gets bigger, but it can't relax to fill as well. And so it just interferes with the regular flow of blood in the heart. And we also have this little appendage, I'll show you a picture of that, that sits on our atria, and that can get larger, and that can cause blood to kind of collect there, which causes other problems like stroke, but we'll talk about that. So there's some structural, the main thing is as we have atrial fibrillation and we continue to have it, we get some changes in our heart muscle too. So what's the problem with having atrial fibrillation? It increases your risk of having other things. 1.5 to 2 times increased risk of dying, 2.4 times increased risk of stroke, 1.5 times increased risk of having dementia, increased risk of sudden cardiac death, and 5 times increased risk of developing heart failure. So that's if you have atrial fibrillation and you're not being managed for it very well. So I know it's a scary thing to look at, but if you're managing the risk factors, number one, that are causing the atrial fibrillation as much as you can, and then managing the atrial fibrillation itself so that your heart's not beating along really fast. We're going to talk about all the treatments for atrial fibrillation. So getting treatment for atrial fibrillation decreases your chance that some of these other things are going to happen. So that's why it's important, number one, to know if you have atrial fibrillation and then to get treatment for it.
I had mine happening.
Yeah,
Church, I was sitting there and I started not being able to do anything. I couldn't stand, and I wondered what was happening.
yeah,
So when I was taken in, they said my heart rate was 144 at that point.
yeah.
And they didn't shock it back, they just let it go, and gradually over about 4 or 5 hours, came back down. So that was
the first time it happened, yeah.
Yeah.
Yeah, so we're gonna talk about that. That's important to know, because some people they don't feel like a fast heartbeat or anything like that. They just feel kind of lousy, right? Have a hard time standing up. Yeah. It's important to recognize atrial fibrillation early, because if you know early that you have it, then you can get on blood thinners to prevent a stroke. If you know early that you have it, you can prevent having heart failure, because there's certain medicines that will reduce some of the structural changes that can have in the heart that causes the heart failure in the heart muscle. It allows for effective treatment, reduces your risk of dying, reduces your risk of dementia, and improves your quality of life so that you can go on and do things that you enjoy and feel pretty good doing them. So down to the most important part of the whole lecture. So how do you know if you have atrial fibrillation? What does it feel like? And it's different for everybody. For some people, it can feel, well, I'm going to ask you guys, what does your atrial fibrillation feel like when you have it? How do you know? You knew because you had a hard time standing up and you felt just wrung out, or? Yeah.
My whole body, it felt like not the pervasive thing like a heart attack, but it was all through my body, my chest area, and I felt terrible.
Yeah. When you say that it was all in your chest area, was it like pressure or?
Kind of like pressure, but not the same time.
Yeah.
As a heart attack pressure.
Yeah. Margaret, yes.
It was lightheaded for me.
Lightheadedness for Margaret, yeah. Marjorie, and that was the only symptoms you had?
Well, I was short of breath, but I thought it was asthma or
Allergies, I remember you thought. So,
It's too early to have these allergy symptoms.
yeah. So how long did you have these symptoms thinking that they were allergies before you found out
You discovered
the irregular rhythm? 4 or 5 months, Marjorie had kind of the symptoms of atrial fibrillation, but thought that it was allergies. And also, as we're older, we think everything is just happening because we're aging, right? Other symptoms that people had, that, yeah.
Well, I was really tired, and I always kept an exerciser and walker.
Yes.
And I got out on my trail one day, and I felt like I was making home,
Yeah,
and I did make it, but I had to really slow down. And then I started getting those
Nice.
Having it. And so I called my doctor right away because my brother had just been diagnosed 4 months earlier. And, so I got seen right away, but mine was persistent from the very beginning.
Wow.
Never went away.
Never went away.
Never. And I did have a cardioversion. And
Yeah.
eventually,
And they think it now it's gone.
well, for now,
Yeah.
I don't know.
Right.
I hope it's gone.
So you may
No,
have
it
been,
hasn't come back.
you may have been having little short runs
Maybe.
for
I
a
wasn't
long
aware.
time. And
Right.
because some people, like I have atrial fibrillation, I had an ablation, but I felt it, I could feel it from the second beat. I could tell that I was in atrial fibrillation. I felt it in my throat. I was
Sometimes
lucky
I could, and it's not like I could feel it in the
when you
chest,
lay
but
down.
when
Yeah,
you're Doing it quiet, I mean, I think if you're doing, but I was able to manage most of the day-to-day things, but exercise very hard.
yes, yeah.
And my heart also felt like flip-flop.
Flip-flopping, yeah,
Felt like that.
right. Flip-flopping heart and decreased exercise tolerance. Anybody else? Yes,
There, I bought a blood pressure monitor that says that it can catch AFib.
uh-huh.
Do those work?
Well, they work, but you're not wearing the exercise. Are you wearing it all the time?
No, it's just when you take your blood.
Right. So, I mean, if you're in chronic atrial fibrillation, yes, that would catch it. But if you're going in and out of atrial fibrillation, which is typically the way that it starts, then it may or may not catch it. You'd have to be in atrial fibrillation when you're taking your blood pressure. Yeah. But that's a good thing to have, because now that you've heard this lecture, if you were to begin to have shortness of breath for no apparent reason, if you notice that your exercise tolerance had gotten worse, you might think, oh, I feel kind of short of breath right now, and I feel just kind of wrung out. I'm going to go put that blood pressure machine on and see if I'm in atrial fibrillation. So in that way, it would be helpful because you've got a way to detect it. Same thing with having an Apple Watch. So what does atrial fibrillation feel like? We talked about most of the things. Some people feel just shortness of breath, like they're having allergies, dizziness or feeling lightheaded, which is probably a little bit of what Ron had. Feeling your heart racing or pounding in your chest. You may feel your heart beating in your throat or your neck. A new weakness or tiredness that you didn't have before. Normally you could go walk your dog for 3 miles and feel fine, and now you can barely get around the block. Or maybe you can only, do 1 mile. Chest discomfort, it may not feel like chest pain, but as Ron described, it may just feel different. Like there's something going on in my chest. I'm not quite sure what it is, but it's not my normal. Difficulty exercising, this is the big one, or reduced exercise capacity. So don't, blame everything on aging, or don't say, well, I haven't worked out in a couple weeks, and that's why I'm feeling like I can't, do the things that I did before. Always good to get it checked out. Why is it good to get it checked out earlier? Why is it so good to catch it early?
So you don't die.
It gets worse.
If you catch it early, that pathway is not very strong yet. And it's much easier for a cardioversion to work, or for an ablation, which is what we're going to talk about. And for the medicines to work. Sometimes just medicines can knock down and get you out of that and let the regular sinus atrial node take over. So catching it early and getting treatment for it, it's a lot easier. If you've been in AFib for a long time, that pathway sometimes is too strong for a cardioversion to work, too strong for an ablation to work. So that's why it's so important to catch it early.
Dizziness and lightheadedness, that can be a lot of.
Yes, all of these things can be a lot of things, can't they? But it's not that hard to get, especially for you all, to get this checked out. You just come in here and make sure that every time we, check your pulse, that we actually check it rather than that little machine. Or we're going to talk about this. I'm getting a little bit ahead. We'll talk about this. So what can you do to catch atrial fibrillation early? Check your own pulse and know what a regular pulse feels like. How many of you guys know how to check your pulse? Raise your hand. Great. So how do you do it? Where do you check your pulse? You can check it in your wrist using your 2 fingers rather than your thumb, 2 fingers. Everybody just check your pulse right now. You can also check it in your neck. Does everybody feel that? And if you don't have atrial fibrillation, it should just feel like dump, dump. And if you have atrial fibrillation, it'll be dump, 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 dump. It won't feel regular. So if you know what your normal pulse feels like, and you start feeling dizzy or lightheaded or just kind of wrung out, check your pulse. If it's going, you know you're in atrial fibrillation. So I'm gonna play this little YouTube video that tells what it kind of sounds like, and you can kind of get an idea from that what it feels like. Browse YouTube.
Just hit return. Yeah.
That
Is it
Let's see.
possible that you could have gone to the doctor for years and they never found?
yes, because you're not in atrial fibrillation when you're there.
Somebody told me I had it, so
Yeah,
that they could miss it.
yes, easily missed.
Are we ready to play this?
Yes, so this is what atrial fib sounds like if you're listening to the stethoscope, but it also gives you an idea of what it might feel like when you're palpating. No sound. Oh, there's no sound on
You hear that, right? Everybody hears it?
Oh.
that.
Not hearing anything.
No, we're not hearing it. Huh. No, it wasn't. It wasn't, oh, that's weird. It's not making any sound. Huh. Well, that's too bad. Yeah, we did hear it by now.
So I think the notion is you would hear a beat every time you have a big wave.
Yeah, I'm sorry that you can't hear it, but it feels like bump, 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 bump when you're feeling it. We just go back to the lecture. Okay, so know what your pulse feels like and check it if you're having one of the symptoms we talked about. Ask the staff here or in the doctor's office to check your pulse and ask if it's a regular rhythm. So lots of times, they'll take your heart rate using that little machine. That little machine is not going to pick up if you have atrial fibrillation. I mean, the thing that you might see on this little machine over here that you put your finger in, you might see that you sit down and your pulse is 60, and then all of a sudden you see it's 100 or 110, and then it's back down to 70, and then it's back up to 110. That's because it's measuring the rate when the atria are going da 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 da. It's measuring that rate as well as when the atria slows down and does a normal beat, which is what happens in atrial fib. It's chaotic. Set your Apple Watch. Any of you that have Apple Watches, there's a way to set it so that you can say, yes, I wanted to detect atrial fibrillation. But you have to actually turn that on your Apple Watch. Let a medical person know if your pulse oximetry shows erratic readings. So if it's showing that your pulse is jumping between 60 and 110, or if you're getting that at home, let your doctor know or let us know so that we can look at it a little bit more closely. Go see your doctor if you're having any new symptoms such as fatigue, shortness of breath, decreased exercise ability, dizziness or lightheadedness, chest or throat pressure.
And this thing is causing you to like pause. Talking to somebody.
That's a brain fart.
Yeah, it sounds more like a brain thing. But I mean, if you're feeling the atrial fibrillation, like I used to be able to really feel it, it could cause you to pause because you feel funny. It's like, oh, something just happened, right? But it's not like you go into a fog, really. No. Yes.
Or is your body temperature? Does that have anything to do with, because sometimes I get flush. Real flush, my body can just get hot.
Yeah. I would take your pulse and see what it is. I mean, everybody's different. It could just be your sympathetic nervous system response to going into atrial fibrillation. I would check your pulse when that happens and just see if it's regular and how fast it is.
Over the weekend, I was like that. I know it's hot.
Yeah.
Sometimes, you get too hot. body temperature.
Yeah. Yeah.
You know, I am sitting with the fan.
Yeah,
I'm still flush.
yeah.
I don't know what.
I would check your heart rate. It could be, if not AFib, it could be some other sort of arrhythmia, like Carrie's going to talk about SVT on Thursday. So you got a lot of heart rhythm stuff this week.
How does that affect your decreased exercise?
Yeah, so if you're, remember how I talked about that the normal way that the heart really works efficiently is the atria contracts together. And when they contract like that, imagine, I mean, you're getting a nice blood flow sent to the ventricles rather than when it's going like this, it's just kind of almost seeping into the ventricles. And then the ventricles are getting a little bit and they're contracting irregularly also because of this message. So instead of this in the atria and this in the ventricles where it goes out to the body, you're getting this trickle through and the ventricles are. So your cardiac output is less, basically. You're having less blood going out into the body. If you're having less blood going out, then the blood is what carries oxygen to the body. So you got less of that going around. So it's okay maybe at rest, but when you try to go walk or exercise, you just don't have enough oxygen circulating around and you feel lousy.
So what's your question, Tom?
Well, that was it. You just.
Yeah.
How does it,
Shortness of breath, I mean,
how does it impact your
Yeah.
ability
Fire.
decreased
Right.
exercise?
Because you're not getting enough oxygen.
you're just.
I don't know why this is not moving forward. Okay, I'll just use that now. Okay, so treatment of atrial fibrillation, which is key. Why is treatment key? You don't want to die. You don't want those pathways to get thicker, right? So there are three main goals of treatment for atrial fibrillation. Number one, you want to prevent a stroke. And if you have, we're going to talk about, well, I'll talk about it right now. If the top part of the heart is kind of going like this, and the blood, instead of going out of the ventricle, it's just kind of hanging out up there, right? Then if blood just hangs out, it forms clots. So you got blood hanging out, it's forming clots. It's going over in this little side unit, which I'll show you on a next slide, and hangs out over there. Really, it really forms clots over there. So, and then the clots kind of travel into the ventricle shoots the clots out into the body. They can go up to your brain. They can go everywhere. They could go to your kidneys and cause a little infarct there. But you can have a stroke because of these clots that form because the atria is not contracting together and strongly and regularly. And the blood's just kind of pooling a little bit there. So you can see in the atrial fibrillation heart where there's all these little conductors over here that are trying to take over, and the atria is just kind of fibrillating like that. Little clots form. In the regular heart, there's no clots forming there. They don't have time because everything's just working together in unison and going down to the ventricles and they're pumping. But they're hanging out here, so see the little clots can form there. The little clots you can see go down into the ventricle. And what happens in the ventricle? That's where the blood gets sent out to the body. So the clots get sent out to the body.
So is it safe to say that if you're in an occupation like working in a prison or even fireman or something, you're always under this constant stress. You may have this all the time.
Well, I mean, atrial fibrillation is not just caused by stress. People can have stress, horrible stress, and not have atrial fibrillation. So you really probably do need to have this genetic predisposition. And then if you have something like chronic stress, like they did a study on veterans that have post-traumatic stress disorder, higher incidence of atrial fibrillation in that group because they felt it was because of the stress. That was their main risk factor in this group. So you kind of have to have both things, a genetic predisposition and then a risk factor such as stress or a risk factor such as obesity or hypertension or being a smoker, those kinds of things. So the two things together really increase your chance of having it. So the main goal of treatment for atrial fibrillation is preventing stroke, managing your symptoms so that you don't feel tired and fatigued and short of breath and all those things. and preventing further progression of the structural changes in the heart. You don't want to get those structural changes in the heart. You don't want to have your atria enlarged and your ventricles enlarged because they're working so hard, because that leads to heart failure and other things. So treatment is focused on 4 main areas: controlling the rhythm, because if that rhythm, even if your heart was going fast and that rhythm was regular, you're going to get a unison of the atria, a unison of the ventricles. And so less likely that you're going to have time to form those clots. So getting that rhythm under control is one of the goals. Getting the heart rate under control. Because if you're going along, if your heart rate's going along at 140, 150, boy, that's working hard all the time. And it's not the kind of working hard that you get with exercise. It's the working hard where your heart is under stress. There, you got more sympathetic nervous system is circulating around your body because it's a stressful, inflammatory type situation. Yes, when you're in AFib, yeah, yes. Preventing clot formation. So if you're in atrial fibrillation, they'll most of the time wanting you to be, unless you have other risk factors for bleeding, then they'll want you to be on a blood thinner. And then reducing your risk factors, the things that cause you to be in atrial fib. So if you have sleep apnea, getting that treated. If you're obese, losing weight, getting your blood pressure control, your diabetes, your blood sugars under control, getting all those things under control is a part of the whole big picture. So we're kind of going to go through these. So treatment of atrial fibrillation, getting your rhythm, your heart rhythm under control. And there are certain medicines that they'll try right off the bat that are called antiarrhythmics. So they try to get you back into a normal sinus rhythm. And they may try this if you're new onset atrial fibrillation right off the bat to see if that can just get you out of it. So flecainide and propafenone is one of them, amiodarone and sotalol. So flecainide and propafenone are sometimes pills that they have you keep in your pocket if you're having paroxysmal atrial fibrillation, which means you're going in and out of it. They say, okay, keep this in your pocket or your purse. If you go into atrial fibrillation, take one of these pills or 2 of these pills. And sometimes that can, if the pathway's not strong, then that can get you back with your SA node, your sinus node, back in charge, conducting correctly instead of this little random group over here. So that's one of the first things that they may try. Then another thing is getting your heart rate under control. So if you're clipping along at 120, 140, you don't want to stay like that. Your heart is working way too hard 24 hours a day, and that can cause structural changes in your heart. So they're going to want to get your heart rate down. You're going to feel better. If your heart rate is 140, 120, and you're in atrial fibrillation, you're not having very much blood going out. There's no time for the heart to fill if your heart rate's clicking along 140. They want to slow down your heart rate so at least your heart has time to expand and fill with blood, even though when it's contracting, it's kind of contracting like this. It's going to help your cardiac output by slowing down the heart rate. So they may put you on a beta blocker, which is any of the medicines that have LOL at the end. Also, beta blockers will help stop that epinephrine, the stress hormone release that I was talking about that you get when you're in atrial fibrillation. They might put you on another medicine called a calcium channel blocker. Diltiazem and verapamil are examples, and they'll slow down your heart rate. And digoxin, it's not used so much. It's an older medication. I haven't seen most people put on that for atrial fibrillation, but can happen depending on kind of what your history is and how your heart looks.
The beta blockers, would that increase the risk of stroke though? Because if the blood is just getting out more, slower heart rate?
It doesn't. It does not increase your risk of stroke. Good question though. The question was, if you slow down your heart rate, isn't the blood just kind of pooling and hanging out more? So would a beta blocker actually help? I think the reason it doesn't is because when you're on a beta blocker, it slows your heart rate down, but it also increases the strength of the contraction. So probably, even though there's a slowing of the heart rate, it's getting pushed out more likely because the strength is stronger. I'll have to look that up. Good question.
Could it also be because of the time begins and the time it ends? So the length of time, what is actually
I don't know what you mean.
well, so you have a certain period of time it's beating. And the slower it beats, the more time it has to contract.
Yeah,
So they have more time to come together and push out more blood.
yeah. It's not really gonna come together too much because it's so erratic, but it is gonna have more time to like fill with blood. So instead of just oozing out a little bit, probably there's more blood that's gonna go out because it's the filling time is longer and the strength of the contraction is gonna be greater. That's okay. So treatment of atrial fibrillation, we've talked about controlling the rhythm. We talked about controlling the rate. Now we're going to talk about controlling clot formation. Having atrial fibrillation increases your risk of stroke by 5-fold. So you're 5 times more likely to have a stroke if you're in atrial fibrillation. And so they will try to put you, unless you have reasons that you can't be on them, they will try to put you on blood thinners or anticoagulants. These medications prevent blood clots, which are the significant risk factor in atrial fib and are the significant risk factor for stroke. So this is a great picture. You can see this little, see that little thing on the side sticking out called the left atrial appendage. So we all have a little bit of that, different degrees of it, but you can see that it's like a little pocket out there. And if you think of like a river, you know how rivers sometimes you're going, it's like good flow down the river, but if there's a little pouching of a river, the water just pools over there and it can even like smell a little bit, it's just not, it's more cloudy, it's just not moving. And so there is a big risk of clots forming in that appendage. And as you stay in atrial fib, that appendage will get larger. So people that have been in chronic atrial fibrillation have larger appendages. So big place for clot formation. And that's one of the big things that causes clots to form, because the blood just goes over there, hangs out, and you have a lot of clots over there. And you can see in this picture, there's kind of some clots that are forming over there. So a treatment besides the medications that we're talking about is to do a cardioversion. A cardioversion is done to try to return the heart rhythm to normal sinus rhythm. And there's 2 types of cardioversion. One is electrical, that's what you're all thinking of. And that's when they put some patches on you, which will shock your heart, transfers the electrical conduction through this machine, and they will have an IV in you and give you medicine that's very short acting, but it will put you asleep. You don't have to be intubated, but they'll give you some oxygen via mask and you'll be out just briefly. It's similar to like what you have when you have a colonoscopy. You won't feel that you're being shocked. So it's very short acting. So they'll put on the electrodes, they'll give you this medicine to kind of put you out briefly, and then they deliver a shock, and that shock is supposed to alarm these other conductors. They're new and they're firing, and it alarms them, and it allows the main conductor, the SA node, to take over again. And so sometimes that works long-term in people. And sometimes if those other pathways are strong, they can more easily take over. And that could be what happened with you when you had the cardioversion. Yeah.
Oh, it's just, I had an SBT
Uh-huh.
and had to have the shot.
Yeah.
In the ambulance,
Uh-huh.
no,
No medicine.
no medicine.
Oh. Oh, that must have been awful. Oh,
It's horrible. It's absolutely,
I don't know why they didn't give you medicine.
they didn't have time.
Oh, your blood pressure probably was dropping and you were not stable. Yeah. Yeah, if you're not stable, they just have to try to do what they can to get you out of it. Yeah. 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 But if you come in for a cardioversion, they will have time and you will get medicine and you won't even know that it happened. Yeah, you had a question?
If you go from AFib to normal, let's say everything drives or something like that, does your heart ever stop? As you come out of it?
No, it kind of looks like this. You'll see the shock there, that big thing up there is the shock, and then the SA node's beating along all the time.
Normal to go from AFib to normal and then having heart stop in between the two.
It's a very short stop. The SA node is still beating along. The SA node's it's beating along when you're in AFib. You just can't see it because those other conductors are so chaotic. Yeah. Then there's another kind of cardioversion that they'll try that I talked about, the pill in the pocket, but they will do those kind of medicines, sometimes bring you into the hospital and give you these high doses of medicines and monitor you. It's not safe to do it outside the hospital because the doses are so high. So they may try to cardiovert you with high dose of these antiarrhythmics.
Does a pacemaker help?
We're going to talk about a pacemaker coming up. Good question. Yeah. So another treatment for atrial fibrillation is an ablation procedure. And it's a procedure that uses, you can either, you go in there and you either burn the pathway with heat, or they burn it with cryotherapy, like a really cold. Usually it's with heat. And it creates scars in the heart tissue, which blocks those aberrant conductors. They might try to conduct, but their pathway has been burned right at the source. So nothing goes down. The SA node is fully in charge because those other pathways have been blocked. So the doctor, it's done, it's a big procedure. It usually takes about 4 or 5 hours because they insert a catheter in through your groin, and then they try to trigger the atrial fibrillation by stimulating your heart. And when they try to trigger it, then they can they actually do a map of your heart, and they can see where all these little aberrant conductor cells are, and they know exactly where to burn. That's called mapping, and the hot spots are found, and that's where they burn these. Typically, these hot spots are where the pulmonary arteries are that come into the atrium. So if they can't get it to trigger, if they can't map and find where the atrial fibrillation is, they have certain spots that they know are the typical spots. So when they did my ablation, they couldn't get the atrial fibrillation to occur. And so he was pretty sure that it was probably one of these spots that are the typical spots that are close to the pulmonary veins. And so I don't know if he could tell by looking at it, if maybe there were little structural changes in the heart right in that area. But when I came out, he said he was 98% sure that he got the spot, even though he couldn't get the AFib to occur. So they kind of, these guys are pretty good at this stuff. And I haven't had atrial fibrillation in about 3 years now, so. So if you're not able to have an ablation, and you just have to kind of live with the atrial fibrillation, then what they try to do is make it so that you feel good. So they'll put you on things that make it so that the rhythm is not so chaotic. They might put you on some sort of antiarrhythmic. They'll put you on something to slow it down so that you're not at a rate of 140 and you can have a better cardiac output. And then they might give you something so that you don't have to necessarily be on a blood thinner, because there's side effects to being on a blood thinner, right? If you fall and hit your head, then you can have a bleed from hitting your head. If you're somebody who rides a bike and you fall off your bike, you could have a bleed in your body. So there's risks from being on a blood thinner. So they might do procedures that take care of that appendage occlusion, take care of that appendage that's sticking out and it's gotten really large and all the blood's going there. They want to block that off so that blood clots can't form there. And if they do, they can't get out of the appendage. So they do left atrial appendage occlusion procedures. And these are some of them. One's called an excision. This is what they used to do. They don't, I haven't seen this in a long time, but they actually do open heart surgery and cut out that appendage over there. This is the little appendage I'm talking about. So it's right there. And then it can get really big, and a lot of blood can pool there. So they go in there, they just cut this off and stitch that up. But I haven't seen that done in a long time because there's much better, less invasive procedures. So one of those is called a left atrial clip procedure. And they used to do a lot of these. They do less of these even. And that's where they just they go in through your groin once again, and they just put a clip on that appendage. And it's like it's not like a paper clip, but it's like one of the clamp, where they just press down and it keeps blood from going in there. The most common one that they do now, and they also do a lariat procedure, which is a similar type thing, where they put they go through your groin, the lariat procedure, they go through the groin, they put one catheter into the left atrium, and that has a magnet on it. And then they put another one that goes not into the heart, but goes around the heart, and it's on the outside, and it's right by that appendage. And it's also got an opposing magnet in it. And the magnet that's inside the left atrium causes an attraction of the outside magnet, and it tells it right where to go. And it goes right over that atria and it creates a lariat. It's like you're using a rope, and then they tighten that down, and then they pull everything out of your groin again. So that was a big procedure, that a common procedure, but now everybody's getting this thing called a Watchman procedure. I do have pictures of here. This is what the clip looks like. And this is the one with the magnet that I told you. One goes through the atria, and then this is the one that's outside the heart, and they get attracted together. And I didn't put the Watchman up there because I have a whole slide for that, because it's the most common procedure and the most popular one, and can be done just through your groin. It's almost like getting a heart cath, very easy. So this is the left atrial occlusion procedure called a Watchman procedure. And it's an alternative for those who can't or prefer not to take long-term blood thinners. It doesn't get you out of atrial fibrillation. It just makes it so that you're not at risk for a stroke, and that you don't have to take blood thinners usually. They insert a small parachute. You can see down there, the guy that's in the hand, that's what it looks like. When they insert it in, that thing is not expanded. It's down like this. It's like an umbrella. You know how an umbrella is not at first not expanded until you open it up? That's what this is like. So it goes through your groin. It's inside the little catheter. You can't even see it. And then once they get it in the right spot, and they can see they're doing a scan on you while they're doing this, they can see right when it's in the right spot. Then they just open up this umbrella, which is the Watchman, and kind of jam it right in the right spot, and they leave it there, and it closes off the left atrial appendage. And originally, Carrie and I just looked this up because she asked me, she said, well, does it completely close it off, or can blood get through there? And I didn't know, so we looked it up. And actually, originally, when they put it in there, a little bit of blood can still get through there. But eventually, within a couple weeks, the heart muscle grows over that umbrella, and it completely occludes the left appendage. So, and even if blood does get through there, clots cannot get through there. So the clots will eventually just kind of dissolve, and that whole area will just kind of not work anymore. So it prevents you from having a stroke, because it prevents clots from forming in that big appendage. And then clots can't get through to the ventricle. And then if they can't get through to the ventricle, then they can't get out in your body and cause you to have a stroke. If none of you asked about a pacemaker, Leonie. So one of the reasons that they might put a pacemaker in is if none of these other things work, if you can't have an ablation procedure done, then they will go in and just, remember how I said there's the SA node, which is, it doesn't show the SA node on this, but the SA node that's in the atrium, SA node, it's really the main conductor, and it goes through the atrium, the atria contract together, and then it goes to the AV node, and then from the AV node, the ventricles contract, right? So if they can't get anything to stop these other conductors, they'll just occlude that, they'll just ablate that AV node. So all those chaotic messages can't get through to the AV node, but nothing can get through to the AV node now, right? Because it's gone. So you have to have a pacemaker that causes the ventricles to contract. So if they ablate the AV node, then they have to put a pacemaker in to cause the ventricles to contract. It's not commonly done. I mean, they try all sorts of other things before they do this. We did.
It's completely dependent
on the pacemaker. Yeah. So another treatment for atrial fibrillation that I talked about briefly, but is so important, is to work on improving the risk factors that you have that you can change. So you can't change genetics, your age, male or female, ethnicity, but you can change your sedentary lifestyle. You can exercise, you can quit smoking, you can treat your high blood pressure, lose weight, improve your profile there, get your diabetes under control. And if you have sleep apnea, get treated for that with some sort of CPAP or whatever works for you. Because you want to avoid all these outcomes that happen if you have untreated atrial fibrillation, right? So not treated atrial fibrillation, but untreated atrial fibrillation. So I'm going to go through these really quickly. This is just how researchers and the American Heart Association grade recommendations. So if it's a class 1, which you look over there, class of recommendation, COR, if it's a 1, that is the best. It means that there's been multiple studies on this, large studies, all randomized studies. So it's a strong recommendation. So strong recommendation for primary prevention. So patients with increased risk. So if you know you have a family history, if you know that you're overweight, or you know that you have high blood pressure, then you want to control your risk factors. So that's a number 1 high recommendation. Patients at increased risk for AFib should control their obesity, physical inactivity, unhealthy alcohol consumption, smoking, diabetes, and hypertension. Secondary prevention, which means if you already have atrial fibrillation, what are the recommendations? So high level of evidence on this one also. Patients who have atrial fib and are overweight or obese should aim toward their ideal weight, or at least a 10% weight loss to reduce the atrial fibrillation burden, recurrence, and progression of their atrial fibrillation. And another, high number 1 recommendation is recommendation for exercise. You asked about exercise. So should do moderate to vigorous exercise training to a target of 210 minutes per week is recommended to reduce your atrial fib symptoms, the burden that it places on you, increases your functional capacity, improves your quality of life. Quit smoking cigarettes. Number 1, high class of recommendation. And they recommend now to eliminate alcohol consumption, because any amount of alcohol puts you at higher risk, not just for atrial fibrillation, but also for heart attack and stroke. So more and more literature coming out on that. But, at least not having more than 1 alcohol, 4-ounce glass of wine a night. Treating your hypertension, treating your sleep apnea, getting that assessed and treated. And then managing all the underlying conditions, avoiding triggers such as alcohol, cocaine, meth, and even cannabis now. I looked this up yesterday. Now more and more studies coming out showing that cannabis increases your risk of AFib, also increases your risk of heart attack and stroke. And exercise, I made a whole separate slide for this. Aim for mild to moderate intensity exercise, physical activity, 150 to 200 minutes per week, which is about a half an hour a day. But so all of that reduces your risk for AFib. But avoid extreme prolonged exercise, as this may be considered, it is a risk factor for the onset of atrial fibrillation. So pushing the body beyond 75 to 90% of your maximum heart rate, long-term endurance activities like those undertaken by marathon running and people who run across the United States, ultra distance runners, or competitive skiers, high intensity exercise exceeding 2,000 hours over a lifetime. So what will you do? So now that you've heard all this is the last slide. So what will you do to avoid, or if you already have AFib, better manage your atrial fibrillation? Any ideas that you've gotten from this talk or that you're inspired to do?
Weight control.
Weight control, better weight control. Yeah.
Keep pressing.
Well, all those things that AFib can cause are not caused if you're managing your risk factors and controlling the things, your risk factors. Yes, continue to exercise. Absolutely. Like you're all doing, like you're all here doing. Yes, front and center in your mind that there's a reason that we exercise. And AFib is just one of those reasons, right?
Sharon, what influence does being properly hydrated have?
Yeah, there's not a recommendation for that. It's not included in the recommendations, but yes, many people who have AFib felt that when they got dehydrated, it was a bigger trigger for their atrial fibrillation. And the same thing for coffee. Like I know darn well that my AFib was, before I had the ablation, was triggered by caffeine. But I looked up and it's not, they've done studies on it and they have not found a correlation for caffeine. But they did say in this article in the American Heart Association that everybody's different. And some people, when they drink coffee, probably just have more sympathetic nervous system going, caffeinated coffee. And so they, I mean, if you have a family history, that combination, more sympathetic nervous system and family history might, or that person might increase the development of AFib. So, yeah.
Second question is, they used to prescribe baby aspirin
Yeah.
for whatever reason.
Yeah.
Is that, and because it cuts in the blood?
Yeah.
Is that
It's not one of the anticoagulant recommendations that they feel makes a difference in preventing stroke with AFib, Yeah.
That's going to help take their blood pressure.
Yeah, right. Yes, absolutely. Huge, huge thing. Yeah, just getting your blood pressure under control and taking your medicine. If you think that your blood pressure medicine is causing a side effect or you're worried about it in some way, talk to your doctor because there are so many blood pressure medicines and a lot of them have been around for 50, 60 years, multitude of studies on them. So there's many of them that are completely safe to take. And so if you are worried about the one that you're on, or if you feel like it's causing side effects, don't just not take it. Talk to your physician and get it switched to a different one, because getting your blood pressure under control is huge in controlling your AFib and preventing all those structural changes that I talked about that can happen in your heart that you want to avoid. As prescribed. Yeah, when you feel, oh, I better take my blood pressure now because I, was stressed from my kids for 2 days. Well, it's a little bit late, probably.
Going back to the hydration thing.
Yeah,
Dehydrated, you're also depleting you depleted your electrolytes, which also play a role. with
right.
your
If you're dehydrated so much that your potassium and your magnesium are low, yes, that causes your heart to be more irritable.
Well, I mean,
I don't know why it wasn't part of the American Heart recommendations, but
a lot of these medications, triple, they want you to be on a low sodium diet. So
yes,
most people are towards the bottom of the normalized scale.
Yeah.
For their electrolytes.
yeah,
And then if they get dehydrated, it tips over pretty
right,
fast.
yeah, good point, yeah,
I had that happen to me actually 49 or something.
uh-huh,
And the effects were pretty dramatic.
yeah,
And I knew it.
yeah,
And so I looked for some place to find electrolytes, and there was a Taco Bell. So I walked in there, and sure enough, they had Gatorade. on the
oh,
fridge.
wow,
Got a Gatorade, and 15 minutes later.
Yeah,
went to bed.
yeah,
So,
yeah, good.
yeah.
Yeah.
You can get in. I mean, I was in trouble.
yeah, so, yeah, watch your hydration. I mean, it just makes sense that it would help with all this. So I just put some of the ideas out here. Better control your blood pressure. Avoid cannabis, weight loss if you need to, better manage your blood sugars or avoid the development of diabetes, mild to moderate exercise for 150 to 200 minutes a week. Some of you talked about that. Stop smoking if you smoke. Avoid or completely reduce your alcohol consumption. Get tested for sleep apnea and then use the treatment. A lot of people get tested and then they have that little CPAP machine and they don't use it every night. So you got to use it. And those machines, by the way, are so small now. Used to be these big things and they made all this noise. You had to sleep in a separate bed. Now they're just small. They hardly make any noise. I went away for a college reunion with somebody and I slept in the same bed with one of my college roommates and she had that. I couldn't even hear it. It's amazing. Yeah.
Unpredictability of the AFib is one of the hardest things to deal with.
Yeah.
You don't know whether it's exercise that causes it or The other night I woke up at 4 o'clock in the morning, my heart was pounding.
Yeah.
You know, and
They don't think that exercise, unless it's really intense, getting way above your target heart rate and a long bout of it, like an endurance type of activity, is not associated with triggering atrial fibrillation. So the kind of exercise you're doing in here is not a trigger for it. But yes, you don't, I mean, yeah, once you start to have that pathway there, it can just happen at any time, whether you had alcohol or not. But there are certain things that you may find that are triggers for you that, every time you do that, you go into AFib. And you want to avoid going down those pathways, because every time you go down those pathways, they get stronger.
is there any way to stop it? Like deep breathing or?
No. Medication, cardioversion, and ablation. So, you are somebody who, I think you only had it probably for 6 months, which is catching it pretty early. And you're going in and out of it. So you're somebody that would be a good fit for an ablation. So, yeah. Yes. Oh, you were just waving. Yeah.
All the talk about who determines the hierarchy, what is done.
It's good to go and get in to see a cardiologist rather than your primary care, because the cardiologist has coworkers that do all of these kinds of treatments. So it's kind of at their fingertips. And what determines the kind of the hierarchy of things is what's going on with you medically. Like if you have kidney disease, what your echo looks like, how big your atrial looks, how long you've been in atrial fibrillation, what are your other comorbid conditions that you have. All of those things, it's a huge decision-making process to determine if you can get an ablation, if you're appropriate for cardioversion, if you can be on any of these antiarrhythmic medicines. Some of them might affect your kidneys, and if you have kidney problems, they won't want to do that. All those things come into play. So it's not necessarily a hierarchy, it's more of an individualized treatment plan. Good question.
And I know what I'm gonna do.
What?
I'm gonna spread the word, because I didn't think this was such a big thing. People don't talk about their heart trouble,
Yeah.
and my people that are my age, they keep telling me they had a stent put in this. Some had 2 or 3 stints, and I don't know what they're talking about.
They're talking about the coronary arteries that sit on your heart that bring blood to your heart can get blocked. And so they put a stent in there, which means they just open it up and make it so it's not blocked anymore.
Well, now I know that too. It's good to get educated and spread the word, I guess.
It's an expandable metal tube, and back when my dad had it done, it was just an expandable metal tube. Now it's impregnated with all kinds of medicines.
Yes,
So
to prevent clots from forming,
prevent
yeah.
clots, but also to help promote the healing because they do stretch out.
Yeah.
things, and so that between the 40 years between
Yeah.
my dad and I, a lot has to develop.
Yeah, they're very good now with those. Yes.
It's kind of interesting, the symptoms, when you look at the symptoms and you say that it's not age related, what is it? I mean, it's like exercise is great, but it's boring.
Yeah.
You know, it's like, that's where podcasts come in and audiobooks and things like that.
Have Carrie come talk to you when you're exercising. That's all. Every time. You won't even know you've done 30 minutes when if Carrie's talking to you.
You'll walk more if you're listening to good.
Yes.
Right.
You know,
Yes.
and or a podcast.
You want to finish that chapter?
You know,
right?
because you're not just thinking about it. Oh my
Right.
gosh. I have
Yeah.
to do 20 minutes.
Yes.
And in fact, you look forward to it.
Right.
Or doing exercise with somebody is very helpful. You're talking to them, you're not even realizing that 30 minutes has passed. If you can find somebody to walk with or, you know. Huh?
Depends on.
Oh, it depends on, well, you might walk faster to try to get away with it. All right, any questions or comments before? Okay.
Thank you.
Thank you guys for coming.
Sleep apnea.
Okay, we can do that. I forgot to tell you, Carrie's gonna talk on Thursday on supraventricular tachycardia. And as always, it will be excellent.
And there will be a quiz on AFib.